We'll continue a little bit the way that I started before, and now we move on to some of the valvulopaties, which in reality is predominantly trying to understand volume loading and pressure loading in some ways better. Now, one basic thing, which I think you really have to understand in cardiac mechanics, and that's also what we have to try to interpret, is that there's an intrinsic relation between the size of the heart, the deformation, the strain of the heart, so the global deformation, and the stroke volume. And they are mathematically, they're strictly related. So if you have a certain ventricle, you have then a certain amount of global strain, that will result in a stroke volume to be generated. If we have less strain, we will have less stroke volume. If we have more strain, we will have more stroke volume. Now, what you also have to keep in mind is that what you do is because of it's the endocardial inward displacement that is doing the volume displacement. So the amount of stroke volume that is being ejected is actually the outer rim, so how the endocardium is displacing. And so that's the amount of volume. So now say that we have a ventricle, but this ventricle becomes bigger and will have the same amount of strain. What you now can see already is that this ventricle, with say 60% of strain, ejects this volume. This ventricle, with 60% of strain, ejects a much, much, much larger volume. And just to show you how much larger this is, so here's an example. Say that you have a ventricle of 8 centimeters, so I mean, it's a reasonably big ventricle if it would be a sphere. If you dilate just 1 centimeter towards all sides, so you become 10 centimeter, you actually increase your volume with 100%. So this volume at the outside is actually exactly the same as the inner volume. So dilatation, even a little bit of dilatation with the same amount of strain, will give you much, much more stroke volume. So obviously this is a way to cope with volume loading, and that's why you dilate in order to cope with volume loading, is to increase the stroke volume while not being able or not needing to develop more strain, because the amount of strain is of course determined by the myocytes. You cannot, or you can only modulate strain very little. The other way around, say that for whatever reason you have a problem with developing strain, say you have ischemia or something like that, or you have a systemic disease. What you now can do is with a much larger ventricle, but with less strain, generate still the same amount of stroke volume. So you dilate in order to, if you dilate and you keep your strain, then that means that you can increase your stroke volume. If you dilate, what you then can do, if you had less strain, you can maintain your stroke volume. So that's why you see dilatation either to cope with volume overload or dilatation either to cope with a contractility problem. Both dilatation will help in order to generate the stroke volume that is required with the amount of strain that you can do. And this is always intrinsically. So that means that also when you do a study and you compare large ventricles with small ventricles, be very, very careful to then compare the strains because they might need different strains. What I was saying this morning is if you look at an athlete, for example, an athlete at baseline can have reduced strain. This is not pathological, but it's just because this large heart generates already the stroke volume that is needed at rest with just a little bit of strain. So you always keep that in mind. Or if you do before and after volume loading and you then look at strain, be very careful how to interpret it because they're intrinsically related. You need to look at the relation of these 3 parameters in order to look at the same thing. The other basic concept which is also important, and I already mentioned this partially before, is looking at the wall stress. That means what do the myocytes feel of the pressure which is inside the ventricle? So how does the pressure translate to the myocytes, or how does the contractile force translate into pressure? And that is related to the geometry of the ventricle. So we said before, a very small ventricle with a small radius of curvature can withstand much higher pressures because intrinsically the wall stress is lower. So that's why a very pressure overloaded ventricle tends to become smaller and smaller because that's a natural way to reduce the impact of the pressure. Similarly, a very dilated heart cannot withstand any pressure loading because that translates immediately into incredible wall stress. And that is geometrically, that's dependent, as I showed you before, with hypertension, for example. So that depends on the shape of the ventricle again. We have normally a very elliptic ventricle because actually you can prove that the more elongated the ventricle, the more efficient volume ejection. But the more elongated, the worse pressure kind of withstanding, because for pressure withstanding you want to be as circular as possible. So we have a balance. So that's also why, for example, the right ventricle is much more elongated in shape than the left ventricle, because it can work under lower pressure, and thus the volume ejection can be more efficient. But of course also, this is then a mechanism to cope with pressure loading. So if you have a longitudinal ventricle and you suddenly pressure load that, it becomes spherical, and by becoming spherical, it can also kind of withstand this pressure better. So these are the concepts that you have to keep in mind. So let's now see what's happening with overload when you have valve disease. Say, for example, you have a leaking valve, you have volume overload. What actually happens is that you need to fill more, because every time you need to fill the ventricle with both the forward and the regurgitant volume. So that means that your filling pressures will increase. With increased filling pressures, all the myocytes will start to replicate their sarcomeres in series. Every myocyte becomes bigger. This is how you dilate. As we said before, by dilatation, while keeping the same amount of strain, so your contractility has not changed, but you can increase your stroke volume and thus your cardiac output, or your overall cardiac output, by this dilatation. So that's what's happening in volume overload. So when you then look at a population of patients with mitral regurgitation, obviously what you see there is that with the amount of regurgitant volume, you will see that the end diastolic and the end systolic sizes will increase, and this is what we use currently for cutoffs. Now the problem is, when you start to look at the size of the ventricle versus the strain, what you then start to see is that in the beginning, with dilatation, actually the ventricles, the strain is not changing. It's not increasing, because you cannot increase strain a lot. You can just modulate it a little bit, but myocytes cannot contract more, so you cannot increase your strain. But what you do is you dilate your ventricle and you retain your strain in order to cope with that. But when we then look at a very large ventricle, so over a cutoff that you would, according to the guidelines, use in order to look at decision making, what you see there, that you actually have two populations. You have a population where the strain is still retained, although they're very big, and then you have a population where the strain is significantly reduced. And what you can actually prove is, if you look at these two populations, what you see is that the one that before surgery, if they would both undergo surgery, the one that has decreased strain before surgery, they will not recover. That means the myocardium was damaged. The one that had normal strains, what they do is they remain the same, they do not have any problems whatsoever. And you can show this. This is actually now a study in aortic regurgitation. You can show that in mitral regurgitation also. So the deformation that you have before, and this can be measured by strain, by ring displacement, by MRI, I don't care. As long as you look somehow to a measure of overall deformation, predominantly longitudinal deformation, because that's the most sensitive also in these cases, then you can actually predict what's going on. So when you look at these patients and you want to do follow-up, and you want to say like, okay, when do I need to do the surgery? What you do is, by following the amount of deformation, irrespective of the size, as long as the deformation remains normal, you know this ventricle is physiologically adapted, is physiologically coping. However, of course, when the ventricle becomes very, very big, as I said before, the wall stress increases. That means that you start to get cells that have such high wall stress that they start to get into apoptosis, you get fibrosis, then you get damage. When you get damage, of course, your contractility decreases. When your contractility decreases and you still need to generate the stroke volume, what you do is you have to dilate. Because I said dilatation is either with the same amount of deformation increase your stroke volume, or with decreased deformation retain your stroke volume. So at the moment that you have cell damage, you start to see that the ventricle dilates, now not anymore to generate more stroke volume, but to compensate for the fact that you have decreased strain. So when we just look at the size of the ventricle, the ventricle keeps on growing. The only thing is that first it does it to increase stroke volume, later on it does it in order to compensate for contractility. And this is also why regurgitation patients suddenly in like 6 months' time can, for example, dramatically decrease or dramatically get worse, because you come into this vicious circle where you're so big, you get cell damage, you have to increase more, of course you get more cell damage, and you very rapidly come into this circle of cell damage and myocardial damage and then deformation, and then dilatation. So trying to follow up regularly how deformation is taking place, and as long as that is constant, even with dilatation, then you know that it's actually not too bad. Now, when we start to go to pressure loading, one of the things that you always have to keep in mind is when you look at deformation, you always have to try to interpret it with regard to what's going on. You try to understand, I see this deformation curve, how does this translate to contractility? Because in some ways, that's what you want to do. And what you see there is that, there's this kind of law of physics, which is called Hooke's law, that tells you that the amount of force that you use on an object and the amount of deformation that you will get because of that is related to the elasticity. So that also is with myocardium, but with myocardium, of course, we have internal forces. So it's the force that makes the deformation, but modulated by the elasticity. So if you have the same amount of contractility, but you have, for example, deposition disease or you have fibrosis, what you will see is that your deformation goes down because your elasticity has changed. Similarly, what you also have to keep in mind is that this force that you have is, of course, the pressure is counteracting this force in some ways. Contractility is used to make pressure, but of course the pressure is felt by all the segments, also the one with less contractility. So the pressure is a loading force for these, and the pressure actually against your contractility. So if your pressure goes up and locally your contractility does not go up, your strain will decrease because overall you have less force at your disposal. And so when we look at pressure loading, then we know what happens is in the end you get systolic increase in the wall stress, and because of that you get hypertrophy, and hypertrophy by definition is parallel replications of sarcomeres in the cells. They become thicker, become hypertrophic, but intrinsically have more force. So contractility in a hypertrophic, compensated hypertrophic heart is increased. So although strain will not increase in your aortic stenosis, you know that contractility has increased because you have more contractile material. And as I said before, one of the things also to compensate is hypertrophy, but shape change is also one way to compensate. And here, for example, you see an acute loading. So if you would have an acute occlusion, in this case of the aorta, or you have an acute pressure loading event, or pulmonary embolus, for example, what you see there is that immediately you start to see that your elliptical ventricle becomes much more spherical, because, as we said before, a spherical ventricle lowers the wall stress for a certain pressure. And you see that actually when you look at the deformation. So you see deformation normally of septal and lateral wall are very, very similar. A normal heart is extremely homogeneous in everything, because that's the most efficient. If we suddenly pressure load, what we see is the septum bulges. Lateral wall cannot bulge, of course, because of the pericardial constraint. And what you see there is that the septal strain can maintain, although it becomes slower. I'll come back to that in a minute. That is also important. But you see that the lateral wall dramatically decreases in strain because of this acute loading. So pressure loading, non-compensated by hypertrophy, will decrease the deformation, while contractility is not changed. So you really have to look at contractility versus loading and see the balance and how it is compensated. And what we said before is also, like Elisa already mentioned this, is we really have to understand the architecture of the heart. So here are some images. These are synchrotron images again, but what is important is to know that your endocardial and your epicardial fibers, they are longitudinal. Your myocytes are longitudinal in the epicardial range, and they change continuously throughout the myocardium, and in the mid-myocardium, they're circumferential. So already when you start thinking about it, what I said about loading, I said flat walls have higher loading than circumferential walls and circular walls. So by definition, your circumferential wall loading or your circumferential stress with loading is less than your longitudinal stress. So when you have pressure loading, by definition, because of the geometry, your longitudinal fibers are much, much more affected than your circumferential. And that is important because that means that is where I was saying with endocardial abnormalities and with pressure loading, you will lose your longitudinal function way before your circumferential. And your circumferential can actually compensate in some ways in order to maintain the stroke volume. And also that has consequences. When we look at, for example, aortic stenosis, we know that severe aortic stenosis for a long time will lead to fibrosis, but it actually leads to very, very specific fibrosis, namely in the septal, infraseptal part, first basal, then potentially towards the mid, but aortic stenosis will never ever induce apical fibrosis just because of the aortic stenosis. If you have an apical problem with deformation or whatever in an aortic stenosis, you know something else is going on, and very often it's concomitant coronary artery disease. So that's another thing to remember is when you look at abnormalities, you expect the first changes with pressure loading always in the base and predominantly towards the septal part, and this way you can really look at these things. And of course, that translates, as we said before, in longitudinal dysfunction. So you clearly see in this case, for example, you see reduced longitudinal function, in this case measured with M mode, which, as I said before, is as good as GLS in most of the cases, as good as MRI 3D. And you see here that it's actually compensated with radial function. So looking at this radial fractional area change, as I also mentioned before, comparing it to the longitudinal is very important, because aortic stenosis has maintained or potentially even increased ejection fraction, but it's only because of this increase, this compensatory increase in the circumferential function, while longitudinal function is down, so it really is the longitudinal function that we should look at. And so by doing this, we can actually try to understand much better these etiologies. So for example, what you will see is like, if we have a low gradient and we suspect a severe aortic stenosis, but you have a low gradient, okay, what's going on? Is this a low gradient reduced stroke volume, so low gradient, low volume aortic stenosis or not? Well, your longitudinal function or your ring displacement actually will tell you. If you have a low gradient and you have a normal ring displacement, so if you have 12 millimeter of longitudinal ring displacement with a low gradient, for sure this is not a severe aortic stenosis because it has no influence whatsoever on the ventricle. If you have a low gradient and you have a decreased ring displacement, you know this is a severe aortic stenosis independent of the gradient. So by combining this information, you can much easier kind of get these patients from differentiating from each other. One last thing, which is also still very important, is that you need to understand how force development is taking place during the cardiac cycle. Namely, when we look at normal force development, what we see is that at the onset of the cardiac cycle, we see force development, we see contractility, and actually your active contractile force is over by half of the ejection phase, just because of the fact that you need time for actually the breakdown of the cross bridges. So what you need, your real relaxation, where your cross bridges and your actin myosin are broken down, that is actually happening in the last or the second half, this last third of systole. So that for the next early filling, you don't have any bound cross bridges and you can efficiently fill. This is because it's physiologically needed to prepare for the next filling. But of course, this gives us a compensation mechanism also to cope with loading. Namely, if we have an acute loading, or it can even be chronic, what happens now is we can actually develop force much, much longer. And that's where I said you have this slower deformation. So you will have the same amount of GLS, but your strain rate is much slower. Or when you look at the M mode, the slope of the M mode is much, much slower. And what you do is you just keep on developing force much longer. But the biggest disadvantage is, of course, that at early filling, you're still not relaxed at the cross bridge level, which means that you're stiff, which means that you have early relaxation abnormalities. So if you have kind of early filling problems in aortic stenosis or hypertension, that can be as much because of the fact that it has to contract much longer than that you would have fibrosis. So diastolic dysfunction in hypertension does not mean fibrosis, not necessarily. It can be that you have functional stiffening because of the fact that you need to look longer. Now, how can you recognize this when this is severe? Well, it's actually quite simple. Once you know what to look for, actually in the aortic outflow pattern, you can see this. So if you see several patients with different grades of aortic stenosis, obviously the gradient is changing. But what you see also is that a normal aortic outflow peaks very early and then is like a bit of triangular in shape, which is because of this force development. When it peaks, maximum force development goes down, you start to get in relaxation already, your flow will go down. So a normal aorta has to peak early. Increased gradient, normal shape, normal peaking, totally compensated aortic stenosis. Here, the same maximum gradient, but much later peaking, this ventricle is struggling because it needs to contract longer. That's also where you have the difference between maximum gradient and mean gradient. So indirectly, what you do with the mean gradient is you also measure whether it's much more extended rather than that it's fully triangular. So there's different ways to look at it, combining maximum with mean or just looking at when the timing or what's the profile. And of course, the more severe aortic stenosis, you see that they use all these mechanisms together in order to do that. But you can actually see this, for example, this is a triple vessel disease patient with coronary artery disease, where you see that the aortic peak is very, very late. The gradient is absolutely total normal, but it changed shape. And that means that what you know is that this ventricle is struggling. It cannot do the normal output even at normal pressures because of the decreased contractility, and it has to contract longer. So integrating all this information will tell you something about what's the myocardial involvement, is the myocardial damaged already, or does it need to use compensation mechanisms in order to overcome that, and then you see that. You see here another example. So this is now a pulmonary, like pulmonary, both pulmonary regurgitation and pulmonary stenosis. What you see here is this pulmonary valve is much, much later peaking and then much longer contracting. So looking at the timing also already tells you, look, this ventricle needs much more time to do the ejection, which means that it either is ejecting against much higher load and is not fully compensated, or is ejecting against the normal load but with less contractility. So these are the ways that you can get information out of it. And just I don't have time to go in detail, but here are 2 tetralogy patients now, and tetralogy makes it even more interesting because there you have a combination of, in your side, so you have pulmonary regurgitation, very often a bit of pulmonary stenosis, and you have right bundle branch block, which again can induce the synchrony. And so here you see 2 young patients, actually athletes with tetralogy. At baseline, they're more or less the same, but at the moment that you start to do exercise, one of the things you see immediately here is this one starts to be really funny in deformation. While this one here seems like, okay, the right ventricle is big, but it seems to be deforming quite nicely. And when you start to look at strains, what you see here is that here, indeed, the deformation increased during exercise, which is what you expect. So that means that the ventricle can cope, it can increase its contractility, that's what you would hope. While this ventricle here, what you see is it becomes totally asynchronous. So it's a totally dysynchronous ventricle. So it cannot at all cope with this loading, but actually the reason why this is predominantly because of the right bundle branch block inducing the synchrony. But so these ways you can really try to figure out all the different underlying etiologies. So the most important thing is that obviously deformation depends on loading, but what you need to see is like, okay, how is deformation changing? Which components of deformation are changing? How is this related with the change in size, the change in hypertrophy? And then also by looking at the dynamics of the outflow, the dynamics of either through the strain or even just with the aortic outflow, you can try to figure out, is this ventricle physiologically compensated? Is it struggling with doing the ejection and does ejecting longer but still has relatively normal contractility? Is it dilating with decreased deformation? Then you know that at some point there is so much damage that this is the only way to compensate anymore. Thank you very much.